So good morning, one and all. So today we are going to see the second part of the physiology of respiratory system. In this episode, we are going to see the physiology of oxygen transport. So all of you know, Joseph Priestley has discovered oxygen in the year 1774. But before Joseph Priestley, Antonio Lavoisier, he heated the red calx of mercury, which he found that it aided in combustion. So he thought it is a pure form of common air. The red calx mercury is nothing but the ash of mercury. When the ash of mercury is heated in high temperature, it will separate to the mercury and oxygen. That oxygen was, he thought, it is a pure form of common air. But subsequently, Joseph Priestley found that it is the oxygen that aided in the combustion. So he discovered oxygen in the year 1774. So today we are going to see the oxygen cascade. What is oxygen cascade? It is the downplay of this partial pressure from atmosphere down to the mitochondria. It is otherwise called the arteriovenous difference of the partial pressure of oxygen. So when we inspire the ambient air, the partial pressure has fall down due to the vapor pressure. Then in alveolar air, it is fall down due to the mixing of the expired carbon dioxide. And when it goes from pulmonary capillary to the arterial blood, the partial pressure falls. It is because of the diffusion defect, diffusion gradient. And from arterial pressure to the tissues and to the mitochondrial level, it comes up to 2 to 5 mm of the mercury of partial pressure. In the venous side, it goes to the alveolar air, then mixed expired air, then to the ampere air, it is expired. We will see one by one. So, oxygen in the biological system, it is the key factor for the aerobic metabolism. Like glucose, there is no storage. Like glycogen, there is no storage of oxygen. It has to be continuously supplied. If there is any interruption of supply of oxygen, the tissue will go for anaerobic metabolism and subsequently die. So the cascade means the oxygen transport from the environment to the mitochondria. So why oxygen is needed for the aerobic respiration? Because in cellular respiration, oxygen is the final electron acceptor. So the oxygen accepts the electron after they have passed through the electron transport chain. So the electron transport chain, the electrons are passed through the 4 domain, 1, 2, 3, 4 domain. And during the passage of the electron, protons are pumped into the intermediate intermembrane space. And these protons are utilized for the production of the ATP through the ATP synthetase enzyme. So finally, the electron that passed through the 3rd domain is captured by the oxygen and it is converted into the water. If the oxygen is not there, the oxidative phosphorylation will not occur and the end organ, that is end substrate pyruvate, will be undergone anaerobic metabolism to produce lactic acidosis. So oxygen is a must for as a electron acceptor of the electron transport chain. So the requirement of oxygen transport system, the oxygen has to meet the demand because there is no storage. So the transport should be efficient. There should not be any wastage during the transmission. And there must be an adequate reserve to withstand limited availability. So there is a reserve is available, no storage is available. You have to know the difference. Reserve and storage. Reserve is available in the form of functional residual capacity and oxygen compared to the hemoglobin. These are called reserve. There is no storage. So the flow of oxygen in biological system, it passes by 2 mechanisms, the convective mechanism and diffusive mechanism. Convective mechanism means the oxygen passes from the atmosphere into the alveolar space. That is called convective mechanism. And diffusive mechanism, it passed down against the concentration gradient from the alveolar capillary membrane up to the capillary tissue transport. So this is called diffusive. So we will see what is convective transport of the oxygen. So the atmospheric air has 21% of the oxygen. When we inhale, it is saturated with water vapor and the partial pressure has fallen down to 19% in the trachea. It is called FiO2. Then when you enters into the alveoli, it further falls due to the expired carbon dioxide dilutes the inspired oxygen. So it is 13.5%. From alveoli, it is expired, and mouth, it becomes 15% of the oxygen. So this movement of the oxygen from the atmosphere to the alveoli and back alveoli to the mouth is called a convective flow. So the convective flow, the oxygen passes from one gaseous form to the another. So it obeys the Graham's law. So what the Graham's law states, the rate of diffusion is inversely proportional to the square root of the molecular mass. That means smaller the mass of the gas, it moves very fast. That is the meaning of the Graham's law. So this is the convective transport of the oxygen from the atmosphere to the alveoli. Then the oxygen passes from gaseous phase to the liquid. From alveoli, it enters into the plasma. Here it obeys the Henry's law. So Henry's law, what it states, the amount of dissolved gas in a liquid is proportional to the partial pressure above the liquid. For example, oxygen 0.003 ml is dissolved in the plasma when the partial pressure of oxygen is 1 mm of mercury above the plasma. When it is raised to 100 mm of mercury, the dissolved oxygen will raise to 0.03 ml. So that is the Henry's law. So the dissolved oxygen depends upon the partial pressure of the gas above the liquid. So carbon dioxide has a high solubility coefficient and it dissolves 20 times faster than the oxygen. Then the oxygen passes from one liquid to another. That is the plasma to the tissue cytoplasm. So the one liquid form to another liquid form. So inspired oxygen, so the atmospheric air, that is dry air, contains 21%. That means 760 mm of mercury is the atmospheric pressure. 0.21% comes around 160 mm of mercury. That is dry gas. When the dry gas enters into the nose, it is saturated with water. So 100% humidity means the water vapor pressure is 47 mm of mercury. So if you deduct 47 from 760, it comes around 713 mm of mercury. So this is the humidified air that enters the trachea. Then PiO2, that is FiO2, means the gas that enters the alveoli that get diluted by the expired carbon dioxide from the plasma. So it comes around 150 mm of mercury. So that is alveolar air. This is the inspired air, that is 0.21% of the gas that is saturated with water vapor. So 21% of the 713 mm of mercury comes around 150 mm of mercury. So this is the FiO2 that enters the alveoli. So in alveoli, this is the alveolar gas equation. In alveoli, the inspired gas minus oxygen consumed is the alveolar oxygen tension. So you know the oxygen consumption is not measurable, but the carbon dioxide production can be measured by the arterial PaCO2. So the ratio of carbon dioxide production to the oxygen consumption, the ratio is called the respiratory quotient. It is 0.8. So you know the respiratory quotient 0.8 and arterial PaCO2. Then you can calculate the oxygen consumption. Oxygen consumption equal to PaCO2 by R, that is 50. 40, PaCO2 is 40, R is 0.8, it comes around 50. So you have to deduct this 50 from the inspired oxygen concentration. So it is to 150 minus 50, it is 100 mm of mercury. So the partial pressure of oxygen in the alveoli is, after the alveolar gas equation calculation, it comes around 100 mm of mercury. So in atmosphere, it was 160. It come down to 60 mm of mercury in the alveoli after taking the water vapor and get diluted by the carbon dioxide. So what are the factors that determine the alveolar oxygen partial pressure is? The first and foremost is the atmospheric pressure. Suppose at the sea level 760 mm of mercury, your alveolar oxygen saturation, alveolar oxygen partial pressure is 100 mm of mercury. Suppose you are increasing the atmospheric pressure, 1 atmospheric pressure, 2 atmospheric pressure. Now the oxygen content of the plasma increases by the dilution of the dissolved oxygen into the plasma. Remember, the oxygen saturation, hemoglobin saturation cannot be increased above 100%. So the hemoglobin bind oxygen remains the same if you increase the atmosphere, only the dissolved oxygen in the plasma increases, according to the Henry's law. So the second factor is inspired oxygen concentration. Suppose you increase the inspired oxygen concentration. See here, if the inspired oxygen concentration is 21, it is around 100 is the alveolar gas partial pressure, alveolar oxygen partial pressure. If you increase to 100, it comes around 663 mm of mercury is the partial pressure of the oxygen in the alveoli. So for every 10% increase in the FiO2, the PaO2, that is alveolar partial pressure of oxygen, will raise about 71 to 72 mm of mercury. So suppose the FiO2 is 1, that is 100%. If you see the inspired oxygen concentration will be 713, and the alveolar oxygen concentration will be 713 minus 50, it comes around 663 mm of mercury. So the third factor is oxygen consumption. If the oxygen consumption is high, the alveolar partial pressure will fall. Then the alveolar ventilation. If the alveolar ventilation is low, the partial pressure will be low. Alveolar ventilation is high, the partial pressure will be high. So coming to the PaCO2, that is partial pressure of oxygen in the systemic circulation, when it goes from the pulmonary capillaries to the arterial blood, there is a fall in the partial pressure of oxygen. This is due to mixed venous oxygen saturation and also the shunt factor. So now the oxygen has reached the alveoli. Now it has to diffuse across the alveolar capillary membrane to the plasma. So this is called diffusive. So the diffusion obeys the Fick's law. What is Fick's law? Fick's law gives the rate of diffusion of the gas through the liquid depends upon these following factors. What are the factors? That is the partial pressure difference across the diffusion barrier. That is the partial pressure difference across the alveoli. In the partial pressure difference across the alveoli is, it is 100 mm of mercury in the alveoli, and in the plasma it is 40 mm of mercury. So it is a difference of 60 mm of mercury. That determines the diffusion of the oxygen across the alveolar capillary membrane. Then the solubility of the gases. High solubility of the gases, it diffuses fast. Then cross-sectional area of the fluid. So more area of contact, there is more chance for diffusion. Then the distance of the molecules that need to diffuse. So for oxygen, it has to diffuse from the alveoli through the alveolar epithelium and interstitial space, then endothelial, capillary endothelium, then it has to enter into the plasma. From the plasma, it has to travel to the RBC, then RBC membrane, then RBC cytoplasm, then only it has to reach the hemoglobin. So this is the distance of the molecule that has to travel. Then the molecular weight of the gas. So oxygen has a small gas. It has a molecular weight of 32. 16 is the molecular weight of single molecule of the oxygen. So the temperature of the fluid, you need not worry about the temperature of the fluid because the body temperature is 37 degrees. Then in the lung, the carbon dioxide has a high diffusion solubility, that is 20 times faster than the oxygen. So the solubility coefficient of oxygen is 0.003 ml and solubility coefficient of the carbon dioxide is 0.06 ml. Even though the oxygen is a smaller molecule, it moves fast. The solubility of the carbon dioxide is higher than the oxygen. Then comes the diffusion gradient. The diffusion gradient for oxygen is higher, 60. The alveoli 100, plasma 40. So the difference is 60. But for carbon dioxide, the diffusion gradient is less, only 5. 45 in plasma and alveoli 40. So it is only 5. Then why we are talking about this diffusion and smaller volume than solubility? Because in disease state, when the lung has a pathology or there is a defect in the ventilation of the alveoli, the first thing to be affected is the oxygen rather than the carbon dioxide. So this is the alveolar capillary membrane. This is electron microscopic appearance. You can see the right side, it is the active side. Here, there is only alveolar epithelium and capillary endothelium. There is no interstitial space. The thickness is 0.3 micrometer. So it is called active side. So the oxygen diffuses through this active side and the other side is called service side. Here, there is alveolar epithelium is there, interstitial space is there and capillary endothelium is there. Here the thickness is 1 to 2 micrometer. So any fluid passes through this side, only service side. So this is another picture of that. The upper side, you can see the epithelium, alveolar epithelium, basement membrane, interstitial space, and endothelial basement membrane. So it has a long distance. The other side, the endothelial basement membrane and epithelial basement membranes are fused together and there is no interstitial space. So gas enters here and fluid enters through the loose junction in the endothelium and the tight junction in the epithelium. So the diffusion into and within the RBC, how it goes into the RBC. So the RBC change the shape as they pass through the capillaries. This plays an important role in the uptake and release of the oxygen. See, this is the RBC. When it is round, the surface area of contact is less. When it takes a biconcave shape, there are large surface area of contact for the oxygen. So you remember the pulmonary capillaries have a mean diameter of 7 micrometer. It is similar to the diameter of the RBC. So when the RBC has to pass through the capillary, it has to squeeze through the capillary like this. It has to squeeze through the capillaries. So what is the advantage of squeezing of the RBC in the capillaries is three things. One, it comes nearer to the endothelium, that is capillary endothelium. And second is this, due to the change in the configuration, the area of contact is more. Then third thing is there is a mixing of the oxygen within the hemoglobin, mixing of the oxygen with mitochondria. So there is a third advantage of this squeezing of this RBC inside the pulmonary capillaries. This happens not only in the pulmonary capillaries, also it happens in the tissue capillaries and aid in the uptake of the oxygen from the tissue capillaries. So another most important is the pulmonary capillary transit time. What is that? The transit time of the pulmonary capillary is 3/4 of a second. Among the pulmonary capillary transit time of 3/4 of the second, only in the first quarter second only the diffusion occurs. The remaining half second acts as a reserve. It helps in the time of increased demand. So when there is a increased heart rate in exercise and when there is a cardiac output increases, the transit time decreases. So the reserve time is utilized for the diffusion. So at that time, when the transit time is reduced, now the uptake depends upon the solubility coefficient rather than the difference in the partial pressure. So that is the reserve capacity of the capillary transit time. So here they have compared the density of the oxygen and water solubility of the oxygen and diffusion capacity of the oxygen to other gases. So the oxygen is taken as 1. It is compared to the other gases. If you see the helium, here the density is 0.125 compared to 1. And water solubility also 0.37. So helium and oxygen, 50-50%. Heliox is used in case of the airway obstruction. But when you see the diffusion capacity, it is similar to the oxygen. Helium diffusion capacity is similar to the oxygen. So healing is useful only for the obstructive pathology of the lung, not the diffusive pathology of the lung. That is the inference. Because the diffusion capacity is similar to the oxygen. It can be used only in the obstructive pathology of the lungs. So coming to the diffusion defect, now there is a alveolar capillary difference of the partial pressure. So this is due to the diffusion defect. It may be a hyaline membrane disease or ARDS. So coming to the concept of the venous admixture and shunt. So various textbooks have different nomenclatures. So Stolting has a complicated nomenclature. So I have taken this from the Chambers 2015. So here they have divided into physiological shunt and pathological shunt. It's very simple. So physiological shunt, it is anatomical shunt and functional shunt. Anatomical shunt means bronchial veins and thespian veins. Bronchial veins which drains from the upper respiratory tract, and thespian veins is the veins drain the cardiac chambers. Then functional shunt is nothing but it is otherwise called VQ scatter. So the lung regions which have a VQ ratio of less than 1 is the functional shunt. The alveoli is perfused, but the oxygen uptake is not, VQ ratio is not equal to 1. It is less than 1. That is the functional shunt. In pathological shunt, it may be intrapulmonary shunt, or it may be intracardiac shunt, or it may be pulmonary AV malformation. So these are the shunt. You remember, shunt is not equal to the venous admixture. So venous admixture is different and shunt is different. We will see there is anatomical shunt, the blood that not perfuse the alveoli and bypass the alveoli. It may be due to your physiological shunt like thespian veins and your bronchial veins, or it may be a pathological shunt of the left to right shunt. So the true shunts, this is called true shunt, are refractory to the supplementary oxygen. It will not respond to the supplementary oxygen. The relative shunt is otherwise called VQ scatters. There is a pathology in the alveoli. It is perfused but not ventilated, or it ventilated, not perfused. So pathology may be in the capillaries, or pathology may be in the alveoli. So it is perfused, but the VQ ratio is less than 1. It is called relative shunt, and this will respond to your oxygen therapy. So what is venous admixture? Venous admixture is nothing but when the shunted blood, this blood and the oxygenated blood comes mixed with each other beyond the alveoli. So that place is called venous admixture. So coming to the oxygen transport in the blood. Now the oxygen has reached the blood. So how it is transported to the tissues. So oxygen transport is in two forms, dissolved form and hemoglobin bound form. Hemoglobin bound form is 98.5 and dissolved form is 1.5%. So dissolved volume in plasma, it is proportional to the partial pressure of the oxygen above the plasma according to the Henry's law, we know. So the oxygen dissolved plasma for 1 mm of mercury of partial pressure of oxygen, it is 0.003 mm. When the partial pressure is raised to 100, that is PaO2 is 100 mm of mercury, the dissolved oxygen will be 0.3 ml per 100 ml. For 1 liter, it will be 3 ml. For 5 liters, that is cardiac output, it will be come around 15 ml. But our requirement is 250 ml per minute. So the dissolved oxygen alone cannot meet the demand of 250 ml. It can give only 15 ml per minute. So we need some other form of transport is needed, that is hemoglobin. So why bound form? Suppose the oxygen content is 3 ml per liter, the oxygen consumption is 250 ml, then you need a cardiac output of 83 liters per minute to meet the requirement of 250 ml per minute. So you need a bound form, that is hemoglobin bound form. We remember the PaO2 we measure in the Clark electrode in the ABG is only the dissolved oxygen, that is dissolved oxygen in the plasma is measured by this Clark electrode. The oxygen that bound to the hemoglobin cannot be measured. It can be done by a calculation based on the ODC curve. So this picture, the distance the oxygen has to travel, that is alveolar capillary membrane, interstitial space, then the capillary endothelium, then plasma, then RBC membrane, the RBC cytoplasm, then only it has to reach the hemoglobin. So coming to the structure of the hemoglobin, you know it has 2 alpha units and 2 beta subunits. In the center of the unit, there is a heme molecule that combines with the oxygen. So every hemoglobin combines with 4 molecules of the oxygen. The hemoglobin molecules with a greater number of oxygen bound to the hemoglobin are brighter. That's why the arterial blood is red and the deoxygenated blood in the vein is blue. So remember, the number of oxygen molecules that bound to hemoglobin increases, the affinity of the hemoglobin for oxygen increases. When a when a oxygen molecule attached to the hemoglobin, it increases the affinity of the hemoglobin for further attachment of the oxygen. That is called cooperativity. So when no oxygen is bound to the hemoglobin, it is said to be the tense form, T state, with low affinity for oxygen. When the oxygen first binds to the hemoglobin, it alters its shape to a relaxed state, which has high affinity for the oxygen. If we don't understand You see this video. So this is the structure of the hemoglobin. It has 2 alpha unit and 2 beta unit. It is in the closed form. That is, it is called tense state. It is closed form. When one oxygen molecule come in contact with the one subunit, it alters the configuration of the hemoglobin. So the hemoglobin is opened up for the attachment of the second molecule of the oxygen. See, it is opened up. The second molecule of the oxygen comes and get attached. Now it further alter the configuration of the hemoglobin. Then it opens up, allow the attachment of the third molecules. And it further changes the configuration and fourth molecule get attached. So it is called a relaxed state. That is called R form. The molecule without oxygen, this is called tense form. It is close to this tense form. Now, what happens? The 2,3-diphosphoglycerate comes in contact with this relaxed form and it causes the release of the oxygen. So this is the configurational change of the hemoglobin according to the oxygen. So coming to the Hoofness constant. What is Hoofness constant? The oxygen binding capacity of the hemoglobin is the amount of the oxygen in ml by each gram of the hemoglobin is commonly known as Hoofness constant. The Hoofness constant can be derived by a calculation. It can be estimated also and it can be derived by a calculation. This calculation is a simple one. One molecule of hemoglobin carries 4 molecules of oxygen. So 1 mole of hemoglobin is 64 grams molecular weight. So 1 mole of oxygen, that is 32 grams of molecular weight, it combines with, it gives up 22.4 liters of the volume according to the Avogadro's hypothesis. Each mole of the any gas occupies the 22.4 liters of the space. That is called Avogadro's hypothesis. Now 4 molecules is there. So 4 into 22,400 is 89,600 ml. So 64 grams carries 89,600 ml of oxygen. So you calculate 1 gram carries 1.3 ml of oxygen. So this is the calculation. It is simple calculation. The number is only annoying, but it is a simple calculation. But when they researchers measured the oxygen capacity of the hemoglobin A2, it comes around 1.34 ml because of the presence of other hemoglobin like hemoglobin A2, methemoglobin and carboxyhemoglobin. Now coming to the uptake and release of the oxygen at the lung level and also tissue level. Now the oxygen has transported along the plasma and reached the tissues. So when the oxygen reaches the tissues that has a low oxygen concentration, the hemoglobin dissociates oxygen and gives up the oxygen and increases the tissue oxygen level. This is called your Bohr effect. The inverse occurs when the hemoglobin reaches the alveoli. Here the PO2 will be low. It continuously takes up the PO2 from the alveoli and PO2 falls. So this is the ODC. What is the peculiarity of the ODC? The upper top is flat. So it favors the uptake and the slope favors the release. So this is the advantage of the ODC curve. If the upper flat, if PO2 of alveolar falls, the loading of the oxygen is unaffected. So the PO2 falls from 100 to 80, 70, but the uptake is not affected in the alveoli. It helps in the hasten the uptake of the oxygen in the alveoli. But in the steep level, for any fall in the PO2, the release will be high. Release of the oxygen to the tissues will be high. So it helps in the uptake, it helps in the release. So what is the utilization coefficient? So the oxygen supplied to the tissues is 100%. If you take it as 100%, that is 20 ml. Only 25% is replaced by the tissues. The remaining 75% are retained in the venous blood. So it is called utilization coefficient. So utilization coefficient is 25%. So what is the relation between the hemoglobin association and dissociation curve? So when the PaO2 is 150, that is oxygen saturation is 150, your PaO2 will be, oxygen saturation is 100, your PaO2 will be 150. When the oxygen saturation is 20%, 25%, the PaO2 will be 20. So that is the critical oxygen saturation is 90%. So 90%, it will fall to 60 mm of mercury. So up to the 90, this is the 90% saturation. When it reaches 90% saturation, the PaO2 has fallen to 60. So it is called critical oxygen saturation. So coming to the ODC, it is right shift and left shift. So right shift has a reduced affinity for the oxygen. So it releases the oxygen to the tissues. Whenever there is an increased temperature, increased PCO2, increased 2,3-diphosphoglycerate, and when the medium is acidosis. When it is alkalosis and decrease in 2,3-diphosphoglycerate and carbon dioxide hypocarbia and hypothermia, it is shifted to the left and increases the affinity. So what is the Bohr effect? So Bohr effect occurs in both level, in the tissue level and also in the alveolar level. So it is a relation to the available carbon dioxide and pH of the fluid. When the fluid is acidic and carbon dioxide is increased, it is shifted to the right. That is low oxygen affinity. When the carbon dioxide is low and the field is alkaline, it is shifted to the left. That increases the oxygen affinity. It occurs in the alveoli, it occurs in the tissues. So this is the Bohr effect. This seems to be complicated. I will simply explain. So Bohr effect, when the oxyhemoglobin reaches the tissues, when there is a tissue metabolism, carbon dioxide production will be high and the environment will be acidosis. So this carbon dioxide and hydrogen ion causes the oxygen to pronation and carbonation. When pronation and carbonation occurs in the deoxyhemoglobin, the oxygen will be released. So that is the Bohr effect. Wherever hydrogen ion and carbon dioxide acts on the hemoglobin for the release and increase the uptake of the oxygen is called Bohr effect. So what is the difference between Bohr effect and Haldane effect? So here this is the oxygen changes its configuration when it reaches the tissues and release oxygen and takes the carbon dioxide and hydrogen ion. When it reaches the alveoli, it changes its configuration. That is rest form. It takes up the oxygen and releases carbon dioxide and releases hydrogen ion. So this is the Bohr effect. The Haldane effect is, it is related to the carbon dioxide. When the deoxygenated hemoglobin has a high affinity for the carbon dioxide. So that carries the carbon dioxide. When it becomes oxygenated at the alveoli, it releases the carbon dioxide. So that is the Haldane effect. So this is the transport of the carbon dioxide. So at the tissue level, carbon dioxide is transported in the three form. One is dissolved form in the plasma. Another is the combined with hemoglobin at the carboxyhemoglobin. And third one is the carbonate form. That is bicarbonate form. That is carbon dioxide combines with water to form carbonic acid. That dissociates into bicarbonate and hydrogen ion. The bicarbonate will be exchanged with chloride in the cytoplasm. Then the hydrogen ion combined with hemoglobin. Hemoglobin is a strong buffer. You remember, hemoglobin is a strong buffer. When the oxygenated hemoglobin releases the oxygen, the hemoglobin takes up the hydrogen ion. It acts as a buffer. So the reverse occurs when it reaches the alveoli. In alveoli, what happens? The hemoglobin takes up the oxygen and releases the hydrogen ion. So the bicarbonate exchanged from the cytoplasm for chloride combined with the released hydrogen ion from the hemoglobin, and it goes into the dissociate into the water and carbon dioxide is released to the alveoli. So this is the transport of the carbon dioxide in the bloodstream. So you will ask, what is double Bohr effect? What is double Haldane effect? So most of them you are confused with double Bohr effect, double Haldane effect. I will simplify this. You remember, this is the placenta. This side is the adult hemoglobin. This side is fetal hemoglobin. What happens? The fetus undergoes metabolism and releases the carbon dioxide. So this carbon dioxide diffuses the placenta and comes to the adult side. So here the adult hemoglobin is there. So the carbon dioxide increases and the pH also decreases. That is, hydrogen ion increases. So the acidosis and carbon dioxide in the adult hemoglobin shift the ODC to the right. That means reduced affinity for the oxygen. So it releases the oxygen. The adult side, the adult hemoglobin releases the oxygen. So it diffuses into the placental side, what happened in the placental side? It released the carbon dioxide to the adult side. So there is hypocarbia. And hydrogen ions also released to the adult that is maternal side. So here also the hydrogen ion is increased. So the alkalinity and hypercarbia shift the ODC to the left. That means it increases affinity of the fetal hemoglobin. It easily takes up the oxygen. So the Bohr effect, this is called double Bohr effect. The maternal side, it releases oxygen, and fetal side, it is taken by the fetal hemoglobin. So the maternal side, it is a tense form that releases. In a fetal side, it is a relaxed form, it accepts the oxygen. So this is the double Bohr effect. The same things occurs in the haldane also. Here, the deoxyhemoglobin takes up the carbon dioxide in the fetal side, and when it goes to the maternal side, in the alveoli, what it happens, oxygenated oxyhemoglobin releases the carbon dioxide. So that is the double haldane effect. I hope you understand. So the total oxygen in the blood, so that is the oxygen content is 1.34, that is Hofner's constant, hemoglobin combined with 1.34 ml of the oxygen, that is 1 gram of hemoglobin, and saturation. It comes around 19.7 ml. So other form of oxygen transport is that is dissolved form. So it is calculated by 100 into partial pressure, that is 100 into diffusion coefficient, that is 0.03. So it comes around 0.3 ml. So totally it is 20 ml of oxygen is carried by the oxygenated blood to the tissues. So coming to the oxygen reserves, what are the oxygen reserves? Suppose you are inspiring room air, the oxygen reserves will be low. FRC will be 450, blood 750, tissues 50, myoglobin 200. So it will come around 1400 only. But when you are inspiring 100% oxygen, the oxygen reserve is increased. See, FRC it is equivalent to the FRC 2750. So blood 950, myoglobin 200. So it comes around 4,000, 4 liters. So the oxygen reserve will be increased to 4 liters when you inspire 100% oxygen. So coming to the oxygen delivery and consumption. This is more important. So the oxygen delivery is calculated by the oxygen content into your cardiac output. So oxygen content is for 100 ml, it is 20 ml. For 1 liter, it is 200 ml. So the your cardiac output is 5 liters. So it is come around 1000 ml per minute is the oxygen delivery. Oxygen, but our oxygen consumption is only 250 ml. So the remaining 750 ml acts as a reserve. It can be utilized at the time of exercise and increased demand like fever. So far we have learned that the atmosphere contains 160. The inspired oxygen concentration due to the dilution of the water vapor content, it becomes 150. Then alveolar, due to dilution of the expired carbon dioxide, it becomes 110. Then pulmonary vein, then come to the arterial blood and tissues. From the tissues, the written blood contains 15 ml of oxygen and 70% saturation. And it goes to the pulmonary artery, then expired gas into the atmosphere. See here, it comes from 160 to 5 mm of mercury in the mitochondrial level. And your deoxygenated blood also carries 15 ml. You can think why unnecessarily the 15 ml is wasted in the venous blood. It acts as a reserve at the time of increased demand. Your oxygen saturation in the venous blood is also 75%. So far we have learned about how the oxygen partial pressure falls from the atmosphere down to the mitochondria and to the back to the atmosphere. So this is more important part of this discussion, that is systemic oxygen delivery. So you know the oxygen delivery is cardiac output into your oxygen content. The most important is that is 20 ml. This is the oxygen content, and your cardiac output is 5 liters. So 1000 ml will be delivered to a tissue. The most important is the oxygen extraction ratio. It is only 25%. Oxygen extraction ratio is the oxygen supply by oxygen consumption by oxygen supply. Consumption is arterial difference of the arterial oxygen tension and the mixed venous oxygen tension divided by the arterial content. This is the supply, this is the consumption. In brain, 3 times of the oxygen consumption is delivered. In heart and other muscles, only 1.5 to 1.6 times of oxygen is delivered. So, for oxygen delivery, what are the important things? The oxygen has to be captured from the lung and it has to be transferred by the hemoglobin, and by the cardiac pump, it has to reach the tissues. So, your hemoglobin cardiac output is more important for the oxygen delivery. So, these are the oxygen variables: cardiac output 5 liters, hemoglobin 12 to 15, and your systemic oxygen uptake is 250 ml per minute. And oxygen delivery is 1000 ml, extraction rate is 25 ml, your arterial oxygen saturation is more than 90, and mixed venous saturation is 75. So, these are the normal values. See, I have already told you, hemoglobin and cardiac output is more important for the delivery of the oxygen to the tissues. Here, see, in cardiac output, when the cardiac output is increased, what happens? Your arterial oxygen saturation increases, and your oxygen delivery is increased, and your mixed venous oxygen saturation is also increased, and your extraction ratio decreases. Likewise, when hemoglobin is increased, your arterial oxygen saturation increased, your oxygen delivery increased, your mixed venous oxygen saturation increased, and your extraction reduces. So, hemoglobin and cardiac output is important for the delivery of the oxygen to the tissues. Then coming to the oxygen extraction ratio, normally it is 0.25. In case of exercise, the extraction can go up to 0.5 to 0.6. When it goes beyond the 0.5 extraction, now the delivery depends upon the oxygen. That is, extraction depends upon the delivery. Here the extraction is independent of the delivery. Up to 0.5, this can operate. That is oxygen extraction. Beyond that, it depends upon the oxygen delivery only. So, always maintain the oxygen delivery 4 times the oxygen consumption. So, that is the concept. You have to maintain 4 times the oxygen consumption as a delivery. So, the important question is, what is the oxygen goals? So, whenever we say what is the hemodynamic goals, we say blood pressure. But it is not ultimately the blood pressure. It should be the cardiac output, and cardiac index is more than your measured blood pressure. Likewise, in oxygenation target, whenever you say the oxygen, we are maintaining oxygen saturation more than 90%. So, that is not the target. The target should be oxygen delivery and oxygen extraction ratio rather than the arterial oxygen saturation. Suppose if you feel the oxygen saturation is below 90% and you take the oxygen saturation as your target point, what you will do? You will increase the oxygen FiO2 and also you increase the PEEP to satisfy the oxygen saturation. But you don't bother about the oxygen delivery and oxygen extraction. So, how to measure this oxygen delivery and oxygen extraction? So, for this help, the mixed venous saturation helps. So, the mixed venous saturation depends upon the arterial oxygen saturation of the hemoglobin, cardiac output, and your hemoglobin. So, 3 factors determines the mixed venous oxygen saturation. Suppose the mixed venous saturation is normally 70. If it is greater than 70, no problem. If it is less than 70, you look at the arterial oxygen saturation. If the arterial oxygen saturation is also low, we give only oxygen therapy or apply PEEP. If the oxygen arterial saturation is also low, then you look out for the cardiac output. If the cardiac output is high, that is normal, then you look out for the hemoglobin concentration. If the hemoglobin concentration is low, you give blood transfusion. If it is high, the high means hemoglobin is normal, cardiac output is normal, only the saturation is low, then assume that the oxygen consumption is high. So, what we have to do is, we have to give analgesia or sedation. It may be pain, due to the pain, they are shivering, the oxygen consumption may be increased. That's why the oxygen saturation falls and your mixed venous saturation has fallen. Suppose the cardiac output is low, then you check whether it is a myocardial dysfunction or due to the hypovolemia. If it is hypovolemia, it can be measured by this pulmonary artery occlusion pressure. Suppose there is hypovolemia, we give you a fluid challenge. Suppose there is a myocardial dysfunction, you give then inotropics. So this is the way to treat your hypoxia rather than looking at the arterial oxygen saturation alone. So at the time of crisis in the last COVID wave, we were struggling to maintain the oxygen supply for the demand. But in milli interior, our body is maintaining the oxygen supply and demand precisely for years together without any defect. So that is the nature. That is the difference between the nature and our human effect. So we cannot overcome the nature, but we can learn from the nature. Thank you. Thank you, Professor sir. Over to you, sir.
Thank you, sir. It was a very nice presentation. Almost covered all the topics what PGs need. Thank you very much, sir. I think it was so clear. We don't have any queries at present. We can move on to the next presentation by Dr. Gurusanthiya, sir. Dr. Gurusanthiya. Welcome, Dr. Gurusanthiya. Dr. Gurusanthiya is a senior consultant in Kumaran Medical Center. She is very good in adapting to very new techniques, and I think she is very famous in her answers in the online anesthesia Facebook forums. So no, she doesn't need a very extensive introduction. She is going to talk on segmental spinal anesthesia. She is going to do a case discussion on that. Over to Gurusanthiya.
Okay. Good morning, one and all. I'm Dr. Gurusanthiya. I will be discussing about a segmental spinal anesthesia in the case of severe COVID-19 pneumonia. And that doesn't end there. We'll look into details in the further slides. This is one such case which is etched in my heart, and I would never forget this case in my whole anesthesia career. She is a 33-year-old gravida 2 abortion 1 who had presented to her OG department throughout the antenatal period with a persistent hyperemesis gravidarum and is on treatment for hyperemesis with antiemetics, thiamine supplements, and pyridoxine. When her OP visit was there, she actually had a generalized back pain for which we had undergone an ortho consult. There was no localizing signs or weakness or tenderness, and hence she was prescribed paracetamol and advised to review. On her 35th week, she was admitted for safe confinement. On examination, she was conscious, oriented. She was ambulating without any support. Her vitals were stable. Ever since her first visit to the hospital, she had a sinus tachycardia of around 110 to 120 per minute. She had vomiting episodes then also, which was persisting till 35 weeks of gestation. She was treated with enteral feeds, which is a class 2B recommendation for persistent hyperemesis gravidarum and IV fluids. And she gained around 2 kgs weight over a period of 1 week and 3 days. During her course in the hospital, she was also investigated in the antenatal period and also during the admission to evaluate the cause for hyperemesis gravidarum if it was missed any. The complete blood count, renal function test, liver function test, thyroid stimulating hormone, because hyperthyroidism can precipitate hyperemesis gravidarum. Serum amylase lipase was done to rule out acute pancreatitis. All were normal. We also had made her to undergo a fundus examination to rule out if there was any ICP rise, and there was no papillary edema. She had ketonuria in urine analysis and hypokalemia following her starvation due to and dehydration, and she had hypokalemia from her vomiting episodes. 1 week to the course of admission, at 11 o'clock, I got a call from our chairman saying the patient has got a cough, an increasing breathlessness, and an epigastric pain following retching after vomiting. So I was the person who attended her. She was conscious oriented. Her BP was around 90-60, and she had a pulse rate of around 140 to 160 per minute. Her saturation was 78% in room air, and her respiratory rate was around close to 40. On examination to the chest, she had a bilateral chest wheeze and creps, which was more on the left side in the mammary, inframammary, interscapular, and the infrascapular area. And immediately I shifted her to the ICU. We resuscitated her with IV fluids, oxygen support, and ICU. Obviously, she was nursed in ICU in the left lateral position. As she did not maintain her oxygen saturation with face mask oxygen of 5 liters to 10 liters and a venturi of 60% FiO2, I initiated her on a non-invasive ventilation as HFNC at that time was not available, or because of a short supply, we had so many COVID patients in our hospital. Bedside echo revealed good LV function and RV was normal and IVC was 0.3 centimeters before initiating NIV and it was fully collapsing. So suspicion of COVID-19 because of the desaturation was made and markers of COVID-19 were sent and continuous CTG monitoring was put once in 1 hour and which was within normal limits. So after obtaining consent from the patient and discussing with the pulmonologist and obstetrician with the leg protection to the fetus, we did the CT thorax, which revealed a CORAD score of 5 with 14/25 score. RT-PCR was sent, but we got the result quite late, which turned out to be negative. The inflammatory markers at that time was significantly elevated. The IL-6 was 1,800 and dimers were nearly 10,000 and CRP was 109. And the total count showed a lymphopenia with the count being normal and NL ratio was increased and the platelet count was normal limits. ABG initially shown a PF ratio of 100. Later with the NIV after 2 hours and then after 12 hours, it improved to 150 to 200. ABG also initially had a metabolic acidosis with a respiratory compensatory alkalosis. Lactate, which was initially elevated, returned to normal after 12 hours of non-invasive ventilation. This is the CT thorax image, which shows a gross, dense ground glass opacities in the subpleural region in the left lower zone and in the right mid zone, it was starting to occur. And the left lung was grossly damaged because of the events of the COVID. We had a multidisciplinary approach where we discussed among ourselves and with the patient to decide upon the timing of LSCS. So we decided to proceed with the LSCS. The anesthesiologist was faced with such a case where she had a hyperemesis gravidarum who had a dehydration, which we were correcting, and a metabolic acidosis secondary to it, which we were correcting. And she had a severe maternal ARDS initially presenting to us with the PF ratios of less than 100. We discussed among our colleagues and our chief to discuss the risk of general anesthesia versus spinal anesthesia. And if spinal anesthesia, so we were discussing about whether to go for lumbar or a segmental spinal. We then decided to proceed with segmental spinal anesthesia in her because of the overwhelming evidence which we had faced. With the NIV support ongoing, we shifted the NIV machine into the operation theatre itself. We shifted her with the NIV support. Her vitals were stable. We kept her on a quite low dose of NORAD when we were going to administer her spinal anesthesia. She still had that sinus tachycardia of around 120 to 130 per minute. We administered her segmental spinal anesthesia at T9 to T10 level. 1.6 ml of 0.5% isobaric ropivacaine was given without any adjunctives. When we placed her supine, because all the way we were nursing her in a left lateral position, in a head-up position. But then when we placed her supine, there was increased need for NIV from 10 centimeters of pressure support to 12. And we had a peak of around 5 centimeters of water. Her respiratory rate settled less than 30 with the NIV itself. Level of spinal anesthesia was adequate and an alive, healthy baby was delivered. Injection oxytocin was only used as a neurotonic. Otherwise, intraoperative vitals were stable. We were able to wean off the NORAD, which we were using in quite some time after the delivery. For the postoperative pain relief, bilateral tab block was given at the end of the procedure using ultrasound guidance. For the course into the treatment after delivery, her oxygen requirement and need for NIV grossly reduced. She was put on face mask oxygen the next day and was weaned off oxygen totally in the third postoperative day. She was treated with remdesivir, steroids, anticoagulants, and ivabradine for her non-specific sinus tachycardia by the cardiologist. The inflammatory markers reduced during the course of the stay, and she was discharged 10 days after the post-delivery. So, is this the end of the story? No, it is just the beginning of another vulnerable story which we had to face. Later into the 10 days post-discharge, she presented to us with the left upper limb weakness. That call was made to the anesthetist also that the patient whom you have given spinal for presented to us with the left upper limb weakness. All of us were in a hurry and we would actually want to look for the cause why she presented with the left upper limb weakness after we gave a spinal. So she was evaluated by the neurologist who advised her MRI brain with spine. She was still ambulant and her vitals were stable, but her left upper limb power was around 3/5. Bingo, we found the cause for all of it. It was a contrast enhancing tumor from a C2 to C7. It's an intramedullary tumor with the syrinx extending up to the medulla. So even though she did not have any fundoscopic examination suggestive of increased ICP, this medullary syrinx would have been the reason she had a persistent hyperemesis gravidarum. And the images were actually suggestive of an ependymoma. We suggested her to excise the tumor as soon as possible to get her admitted on the same day itself. But then she presented 1 month post-delivery with bilateral lower limb weakness with spasticity and caesarean gait, and bilateral upper limb weakness with the left greater than right. The left power was 3/5 and the right's power was 4/5. She was counseled for surgical excision of the cervical tumor under intraoperative neuromonitoring. She was treated with analgesics, baclofen, gabapentin, and optimized in the perioperative period. This was the CT, chest X-ray taken just prior to the surgery. And out of curiosity, we did a COVID antibody because the RT-PCR was negative. The COVID antibody was positive. The sinus tachycardia, which is the worst culprit, still persisted. And anesthesia for tumor excision was actually given as in we would give for any another neuromonitoring. For initially, we had given her fentanyl, propofol, and atracurium. Then we had a propofol TCI at 2 mics per ml concentration. Then ketamine at 0.5 milligram per kg per hour, and dexmed at 0.5 mics per kg per hour. Due to the sparsity of vein from the previous admissions, we had to actually cannulate her right subclavian vein, and we also cannulated the left radial artery for invasive blood pressure monitoring. These were the monitors used along with this. This is the intraoperative neuromonitoring picture. Because of the gross tumor which was there in the cervical area, she actually had a gross decrease in the amplitude of whole of the neuromonitoring which was done in the intraoperative period. Post-tumor excision, she actually had a persistent weakness in the left deltoid, which also persisted in the images also of the MEP. The SSEP was grossly not interpretable because of the tumor in the cervical region. The left deltoid weakness persisted. With intense physiotherapy sessions, the patient drastically improved, and she presented to us now to vaccinate herself for the second dose of COVID vaccination also. She is again a mystery where all the images showed she had an ependymoma. The biopsy showed she had a pilocytic astrocytoma. So our concerns for this patient were many. And these are the following. She had a persistent hyperemesis gravidarum into the 3rd trimester. She had a COVID-19 pneumonia who was on an NIV. There was also a concern of our staffs with the aerosol generation with NIV. We were actually planning her to give a segmental spinal anesthesia in a patient with the severe maternal ARDS. And a patient later then presented with the spinal cord tumor, which actually she had in pregnancy. So coming on to discussion, I would discuss about hyperemesis, COVID, and also spinal cord tumors in pregnancy. This is a differential diagnosis of nausea and vomiting in pregnancy. See, the gastrointestinal conditions and the genitourinary conditions, we were able to rule out with the ultrasound abdomen and pelvis, which was found to be normal. To rule out pancreatitis, we actually made her to undergo serum amylase and lipase, which was normal. To rule out diabetic ketoacidosis, we actually checked her RBS and urine routine, which was also normal, except for the ketonuria she had. Echo was done to rule out any cardiomyopathy of pregnancy. She didn't have any. Her echo was normal except for the collapsed IVC. LFT was done to rule out any acute fatty liver of pregnancy. That was within normal limits. The fundus examination was done to rule out any brain tumors which would precipitate an increase in ICP. We had no way of ruling that out. She had no papillary edema. She was ambulant and she had nil weaknesses to know about any vestibular disturbances or spinal cord tumors which would actually point us towards doing an MRI. Since she had been a moderate to severe case of hyperemesis gravidarum, she was treated with pyridoxine, doxylamine, metoclopramide, and ondansetron. We actually tried her with an enteral feeding, which is a class 2B recommendation according to the guidelines, for 2 days, but then she did not tolerate it. So we had stopped it and started on IV fluids since she had signs of dehydration and ketosis. We actually tried to start her on hydrocortisone. Later then she presented with the COVID features, for which actually we started her on steroids because she had desaturation. The supporting evidence for using non-invasive ventilation in such cases has been there in the Lancet Journal and the Clinical Respiratory Journal from the start, that the effectiveness of non-invasive ventilation has been shown that it can avoid intubation in timely periods in about half of the patients they have seen. So if the patient had not shown any improvement with the NIV, then we would have thought to switch from NIV to intubation, but then our patient improved over a period of 12 hours. So we continued with NIV. This is again, these are the studies from Lancet which actually prevented us from giving an invasive mechanical ventilation to this patient, because the ICU mortality rate among those who were in the subsequent journals which the Lancet has given. And actually it led us to think about spinal anesthesia rather than going in for an invasive mechanical ventilation in this patient. So our staffs were very much concerned about aerosol generation and the risk of being exposed with an NIV ongoing in the operation theatre itself. There were studies also saying that the non-invasive ventilation, they do not significantly increase the aerosol generation from the respiratory tract. And we also have in the Respiratory Journal of American Journal that the HFNC and NIV are not associated with the as increased risk as we would have thought previously about the risk of getting an aerosol dispersion. Of course, we all had a PPE in place, but then this was the reason we actually went ahead with NIV and proceeded. Coming on to segmental spinal anesthesia. This was one bold choice which we made because of the evidence which were available, and we wanted to not every time common things are uncommon, but we also have to look for uncommon things and try out if it would work out in that particular patient. We actually went ahead with the evidence that the paresthesia and the neurological complications, there was no neurological injury in 300 patients which the study was done. And in the anatomy of thoracic and spinal column, the magnetic resonance imaging showed that the spinal cord is more anterior in the thoracic area than in the lumbar area. So we went ahead with the spinal anesthesia. There is also a case report from Ames Journal saying that they went for a thoracic spinal anesthesia. Here they have used 0.5% heavy bupivacaine 1.2 ml, but we used isobaric ropivacaine. And we also wanted to explore a new dimension because this patient also had so many dimensions for it to think about. And there are also very many case reports suggesting that in a case with severe lung disease, where do you think that any compensation would occur if you go for an invasive mechanical ventilation? Then you can actually go for a segmental spinal anesthesia rather than subjecting the patient to general anesthesia. So this made us to take the choice for segmental spinal anesthesia. The invasive mechanical ventilation was associated with the poor prognosis when we actually had this patient. Our patient was tolerating NIV and was improving with NIV. NIV was feasible to be used in OT and to proceed also. The patient was comfortable with NIV rather than invasive mechanical ventilation is what we thought from the picture of the patient who presented to us. In case of any severe lung disease or whom do you think general anesthesia may compromise or invasive mechanical ventilation may compromise their lung function, then a spinal anesthesia segmental is a potential option to consider. In case of a lumbar spinal anesthesia, the sympathectomy which you produce in a caesarean section, provided the level is still T4, the sympathectomy is total and complete. But in segmental spinal anesthesia, the sympathectomy is incomplete with the legs are free to move. There is no gross vasodilatation. So the sympathectomy is incomplete. So you can expect a better hemodynamic stability in this case, in case of a segmental spinal anesthesia, and lesser dosage of the drug used. This made us to choose the segmental spinal anesthesia rather than a conventional lumbar spinal anesthesia in this patient. Coming on to spinal cord tumors in pregnancy, most of the women who are pregnant, 17% of them usually exhibit a lumbar sciatica. This doesn't mean that the patient has got a cervical cord tumor or so, but there are case reports where the patients have got numbness or sciatica, later then diagnosed to have a thoracic or cervical or a lumbar spinal cord tumor following pregnancy. The incidence of spinal cord tumor is around 0.5 to 2.5 per million per year, and most of it are intramedullary. Astrocytoma, as our patient had, is a slow-growing tumor, and survival rate has been better with the thoracic astrocytoma than a cervical astrocytoma. Our patient is doing good, ambulating herself with a mild left upper limb weakness of 4+/5, still presenting to her hospital for her regular postnatal visits and also for her visits to vaccinate herself. So my take-home message would be the MRI, the need for MRI as a screening tool to rule out any intracranial or spinal cord pathology needs to be elucidated in a case of a persistent hyperemesis gravidarum, because fundus examination did not reveal any papilledema in our patient. Segmental spinal anesthesia can be a potential option to any maternal patient who has an ARDS or who has a severe lung compromise. I owe all this to my alma mater, Madurai Medical College. Thank you.
Thank you, Gurusanthiya. That's a very nice presentation. Shall we take on some questions? Some people have entered chat box. What were the spinal segments blocked when you gave the segmental and spinal anesthesia?
So grossly from T4, up to T4 it was blocked, sir. We were able to elicit that up to T4 was blocked. She was able to move her limbs post-procedure. We were able to ambulate her also. Her legs were mobile only. So only the thoracic segments got blocked, sir.
Okay.
From T4 to L1. We were sure of it because she was able to move her legs. Actually,
very witfully gone through many problems and successfully taken this baby out. So if this segmental spinal anesthesia hadn't worked, then what would have been your alternative plan?
We would have gone for general anesthesia, obviously. We had everything ready. As any anesthesiologist would, we had everything ready for, we actually educated the patient also that this is what is going to happen. If this doesn't work, we would actually change herself to a general anesthesia is what we planned. We discussed with the obstetrician also that this is our plan, so and so, because of the comorbid illness she's having. We would try this out. If this is not working out, then we will go for an invasive mechanical ventilation and wean her off whenever she comes out.
Okay. I think that would be fine. How about the patient comfort during the segmental spinal anesthesia?
She was comfortable. She didn't have any pain. She was comfortable. We were able to grain her up. She was quite a comfortable patient to deal with. She was afraid, but she cooperated very well, and she did very well through the surgeries. There was no need for any other adjunctives to be given during the surgery.
Okay, there is one question asking why didn't you go for an epidural?
So again, the choice is made because with a single prick and a single injection, we would actually mitigate all the effect is what we thought for. We actually did think about epidural, but then the level to which to give to and the level of T4 we would actually require, if at all I'm using say 2% xylocaine with adrenaline, then again I would need 10 to 12 ml, which would precipitate a hypotension in her. She was already in the borderline. I didn't want to load her with so much volume and land her in hypotension because of that. So a graded epidural would have still been a choice, sir. I accept.
Definitely. Okay. I think that is all for the queries. Shall we go on with the video presentation, sir?
Yes.
The next one will be an interesting video on interscreen block and its performance. This is presented by Dr. Divesh Arora. He is from, welcome sir. He is from Asian Hospital, Faridabad, Haryana. His special areas of interest are on quality and safety in anesthesia, USG guided regional anesthesia, fluid management strategies, and intraoperative lung ventilation strategies. It is also interesting to note that he is a green OT assessor. I think it's a relatively new field coming in. Welcome, sir. We are eagerly awaiting for your video. Over to you, sir.
Good morning, everyone. Thank you for the introduction, sir. At the outset, I'd like to thank Dr. Johnson as well as Dr. Gurusanthiya for giving me this opportunity to be in this nice initiative of online postgraduate teaching program. I bring greetings from Asian Institute of Medical Sciences. This is a 425-bedded hospital located in Faridabad, Haryana, where I've been working for past 11 years, and it's very close to Delhi NCR. So I'll be talking about interscalene block. These are some of my learning objectives, which I'll be covering through my lecture. So ultrasound guided interscalene brachial plexus block is a regional anesthesia technique wherein we deposit a local anesthetic in the interscalene groove to block C5, C7, C6 and C7 nerve roots so as to produce the ipsilateral block of shoulder and the proximal arm. So first we'll deal with the anatomy of the brachial plexus. So brachial plexus, as we know, is formed by the fusion of ventral rami of C5, 6, 7, 8 and T1. And in the interscalene groove, we get a hypoechoic picture located between the two scalene muscles, which is also reported in literature as a traffic light signal, snowman signal, or stoplight sign. The brachial plexus is situated deep to the posterolateral edge of the sternocleidomastoid in the neck in the interscalene region. However, because of the hypoechoic appearance, the ventral rami can have an appearance similar to blood vessels, which also appear hypoechoic. For our understanding, we have to remember that the 7th cervical ventral ramus is usually the largest, which I'll be showing you in one of my sonoanatomy videos also. So if we look at the cross section at the level of C6 and C7, we realize that the C7 does not have the anterior tubercle. These features will be utilized during sonography for identification of appropriate nerve level, vertebral levels, as well as the nerve root levels. So my friends, I would like you to pay attention to this article by Manoj Karmakar, published very recently regarding high definition ultrasound imaging of the elements above the clavicle. Initially, we were taught 10 years back that the traffic light signal is composed of C5, C6 and C7. But over the years, because of a better resolution of ultrasound machines, or because of the better understanding of the regional anesthesia anatomy, now we realize that the C6 as well as C7 are actually split inside. So what we were initially calling it as C5, C6, C7 actually might be the C6 split root also. So traffic light would be red, yellow, green, and it would be actually a 2 split C6 nerve roots. So this has led to an improved understanding, and this feature I'll be showing you in my sonoanatomy video also. So coming on to the technique, how do we actually do this block? So this block can be done in the supine position and in a beach chair position, as is done for shoulder arthroscopy, or lateral position also. So it's a superficial block, so we need a high frequency linear transducer. As you can see from this image, we need to have a transverse oblique orientation of the probe. A 5 centimeter, it's a superficial block, so 5 centimeter needle is generally sufficient. In plane approach with a needle direction from lateral to medial is what is desirable. So drug, as I'll be showing you in my videos, has to be deposited in between a periplexus injection, like between brachial plexus sheath and the middle scalene muscle. So as PG students, when we start our ultrasound guided procedures, we are foxed that how to place our probe, which probe to use, where should the operator stand, where should be our USG machine, what should be the axis of visualization, what should be axis of intervention, what local anesthetic, what adjuvant, and what should be the goal. So I made a small mnemonic, which is by Pout Wind Lag, and this can be used by the PG students, and it is applicable for any kind of block or regional anesthesia procedure which they intend to do. So coming on to the ergonomics, not specific to interscalene, but specific to any kind of regional anesthesia technique, the long axis of the transducer, how is it aligned with the visual axis, gives us two basic approaches. That is the along approach, another one is the across approach. In the across approach, you can see the long axis of the transducer is perpendicular to the visual axis. There are various studies, I am quoting one of them, that whenever we have the long axis of the transducer aligned with the visual axis, which is known as the alveolar approach, we have a better needle imaging and we need a shorter time to perform the block performance. So this is the one which we'll be utilizing for description of interscalene block. So let's look at the ergonomics for right-sided block. This is the along the line axis. As you can see, the long axis of the transducer is aligned with the needle. Whereas if you can see, it is the across. And because on the support of the literature, we realize that it leads to a longer time. We can ourselves see that the needle cannot be in precise location with the probe. That is why we prefer a long approach. Similarly, for the left side, we stand on the side of the patient between the head and the shoulder. So the key is that you have to stand between head and the shoulder, irrespective of the fact right or left. The machine has to be on the opposite side, and you are using the along the line of visual axis approach. So once we place the probe in the interscalene close to the cricoid cartilage, this is what we get. The posterolateral edge of the sternocleidomastoid, anterior scalene muscle, middle scalene muscle, and the interscalene groove with the nerve roots stacked one above the other. And on top of anterior scalene muscle, we can see the phrenic nerve. So how do we recognize? These are generally round to oval hypoechoic structures and a very thin rim of hyperechoic connective tissue. So I'll be showing you the video of the sonoanatomy of the interscalene groove. Whenever we plan to give the interscalene block, it's always worthwhile to start from the supraclavicular fossa close to the clavicle, as we would do it for a supraclavicular block. So once we place the probe in the supraclavicular fossa, we see the subclavian artery, the brachial plexus. This is the cluster of grapes. As I start to move my probe cranial in the neck, we get to see the bulk of anterior scalene muscle and the middle scalene muscle. In between the two, the nerve roots are stacked. So slowly and slowly, I am moving the probe a little carefully. I get to see the C7. So I'm stopping the video. What I get to see is the C7 posterior tubercle. As in my initial slide, I showed the anterior tubercle is absent. So C7 is diving towards the intervertebral foramen. Subsequently, C6 will divide. Subsequently, C5 will also divide. As you can see that the C6 is a bifid. So this will be demonstrated more in the further video also. So C7 is diving inside the vertebral foramen. Next, it's a vascular area. This is the vertebral artery. It's worthwhile to apply Dopplers so as to identify the vascular structures clearly. C7 is diving. Now is the turn of C6. So C6, the posterior tubercle is of less height as compared to the anterior tubercle. Anterior tubercle has a special name known as a Chazak-Snack tubercle. So C6 nerve root is also diving inside the intervertebral foramen. Okay, as you can yourself see for it. So as I move a little more cranial, the C5 nerve root will be diving inside the. Here you can see the anterior and the posterior tubercle are almost equal size. Then I begin to slide my probe again back towards the clavicle. You see C5, C6 coming out. C6, I'll stop the video. C6, you can yourself identify as got a split in nature. So actually, it is a bifid in appearance. Similarly, C7 also I'll show is got a little bifid appearance. So I'll stop the video again. C6 bifid, C7 bifid, C5 is here. So this is how we have to trace the respective nerve roots as well as the vertebral levels before actually attempting an interscalene block. So now I'll show you the actual block video. Needle will be coming from the lateral. This is the medial. This is the anterior scalene, middle scalene, C5, C6, C7. So the idea is to bring the needle close to the nerve roots, but not actually going through inside the nerve roots, in between or inside. We are giving a periplexus injection, as you can see, between the middle scalene muscle and the neural elements stacked in the interscalene groove. So this is known as a periplexus approach, and this approach avoids the neurological damage to the structures as well as reduces the incidence of the hemidiaphragmatic paralysis because phrenic nerve is situated somewhere close to it. So as we have realized, there's a lot of neural element and very less of connective tissue element. But as we progress distally, the connective tissue element also increases and the neural element decreases. But interscalene groove is classically known for a lot of neural injuries. So that is why periplexus injection is advisable in this region. So rest of the video, we can see the drug is being injected and we are completing the block. So ideal technique would be the periplexus approach. So the indications, as we can see from the anatomical knowledge, involves the surgeries around the shoulder, the clavicle, and as a part of scapular block. In the prospect guidelines in 2019 regarding the rotator cuff repair surgery, interscalene brachial plexus is recommended as the first regional anesthesia technique choice, and the shoulder block, which means the suprascapular with or without axillary nerve block, is generally considered as a second choice. So complications, neck has got a lot of neural structures as well as vascular structures. So the complications as per case reports can be many if we do not pay attention to them. So it can result in a phrenic nerve block, lung and pleura is quite close by, so pneumothorax. Since the connective tissue is very less, and as a beginner, we can go inside the nerve roots or go intraplexus, we can have neurological injuries. Horner syndrome has been reported, and the nerve roots are in continuity with epidural or subarachnoid space. So this is also a possibility, and vertebral injection is also a possibility leading to LAST. So contraindications, there are general contraindications, the first three to any kind of regional anesthesia technique, but for specifically for interscalene block, there is a pre-existing brachial plexus or distal nerve if they are already injured, so please avoid. Any kind of contralateral respiratory impairment should be an absolute or relative contraindication, and severe bilateral lung disease. You must think in mind that if by your injection you are going to cause paresis of the phrenic nerve, then it might be a cause for trouble for the patient. So I'll be doing a review of literature and try to answer what is the optimal volume, concentration, how to prolong the duration, where should we deposit the drug, and how to avoid phrenic nerve palsy and dorsal scapular nerve in long thoracic nerve injury. And is there any alternative to interscalene plexus block for shoulder analgesia and anesthesia? The first is regarding the dosage of local anesthetics. So this is an interesting article published in 2011, where they found that the minimum effective volume to produce the interscalene brachial plexus block is 5 ml. In 2013, they tried to find a minimum volume through the catheter, and they found it 7 ml. So on the basis of these two articles and many more, the optimal volume is between 6 to 10 ml for analgesia, and the concentration is 0.2% ropivacaine or 0.2%, 0.1 to 5% bupivacaine or levobupivacaine. And if we intend to achieve surgical anesthesia, then we have to increase the volumes to around 15 ml and use a higher concentration of the local anesthetics, that is 0.75% ropivacaine or 0.5% bupivacaine or levobupivacaine. And whenever you insert a catheter, use a loading dose around 7 to 10 ml, then every hour around 4 ml is sufficient to produce analgesia. So next question which comes to our mind is where actually to deposit the drug? Along the plexus or inside the plexus, as you can see in this video. So as I have already told you that at interscalene groove, the neural elements are the predominant ones. Connective tissue is very less. And as a beginner, we may not be able to identify whether it's a split C6 nerve root or C7 nerve root. And we may think that there is a reasonable gap where we can actually insert the needle. So my friends, there is enough evidence in the literature that periplexus approach is more safer. Plus, in terms of analgesia, in terms of the opioid requirement, it is not different from intraplexus block. And plus, the biggest advantage is that the phrenic nerve palsy is drastically reduced. In one of the studies published very recently in Indian Journal of Anaesthesia, intraplexus had a 46% of phrenic nerve palsy chances, whereas for periplexus, it was reduced to around 17%. So as early as 2011, Spence et al. Stated their periplexus recommendations. It was again confirmed in 2016, and now, as I have been quoting, Indian Journal of Anaesthesia also. So for everyone, periplexus should be the choice of drug deposition. So how can we actually prolong the duration of block produced by local anesthetics in interscalene area? So we can add certain adjuvants, we can use catheters, and we can use liposomal bupivacaine. Dexamethasone is a universal adjuvant. Generally 4 to 8 milligrams is useful, which I've been using for almost each and every kind of block which I give. Catheters can be inserted, as I've said earlier, 4 ml loading dose, 7 ml is sufficient, and then subsequently 4 ml per hour of ropivacaine 0.2%. Liposomal bupivacaine is not available in India, but wherever in 2018, it was approved by FDA for interscalene blocks. But it has gone kind of a mixed review In some of the studies, there is no benefit over traditional bupivacaine, but in this small meta-analysis, it has been seen that liposomal bupivacaine improves the pain scores. So coming on to the number one kind of complication or side effect which everyone dreads is the phrenic nerve palsy. Traditionally, if we recollect 20 years back, and we were using landmark-based technique during my post-graduation at Jamnagar, we used to give 20 mL of 0.5% bupivacaine. And as the literature states, it can lead to phrenic nerve palsy in 100% of the cases. Let's understand the anatomy first. So it's a monofascicular nerve. It's less than 1 millimeter in diameter. It has got contribution from C3, C4, C5, but principal contribution is C4. At the level of cricoid cartilage, it is seen very close to the C5 nerve root at this level. Subsequently, as we move downwards towards supraclavicular fossa, the nerve moves on the surface of anterior scalene muscle from lateral to medial at a rate of 3 millimeter for every centimeter we move downward. So at close to supraclavicular fossa, when we give supraclavicular block, it's almost 2 centimeter away from the site of injection. So traditionally, we were giving injection at this level using landmark technique, but with ultrasound, we are giving injection at this level. So almost the distance has increased to around 0.8 or 1 centimeter or so, thereby reducing the chances of phrenic nerve palsy. So this is a small video where I'll show you how to identify phrenic nerve. It's located on the top surface of the anterior scalene muscle. This is medial scalene muscle and the interscalene groove. So as we scan up the neck from the supraclavicular area, you can see a very small tubular structure approaching almost the C5 nerve root and getting into it. So this is the picture we get at the level of cricoid cartilage. And as we start to move downward again, so now we realize that it keeps moving from lateral to the medial direction. So majority of the cases, you will be able to identify the phrenic nerve. So another two important nerves are the dorsal scapular nerve and the long thoracic nerve. Both of them are situated in the middle scalene muscle. But it's not that easy to identify. But majority of the times, very close to the C6 nerve root, they can be seen 1 centimeter posterior to it. So the easiest way, in my opinion, is whenever you are scanning in the middle scalene muscle, try to look for hyperechoic shadows. Whenever you find some kind of hyperechoic shadows, presume them to be nerves and try to negotiate your needle in such a way that it comes in between these two nerves, or you get above this area. So once we scan a little more, you get above. So the certain tips which have been cited in the literature is use a shallow needle trajectory. Instead of getting from here, if you come from this place, you will use a shallow needle trajectory and you will not come in between both these nerves. And use of nerve stimulator is helpful. So are there any alternatives to interscalene brachial plexus block so as to avoid phrenic nerve or to injury to dorsal scapular or various other complications? This is very recently published diaphragm sparing nerve blocks for shoulder surgery revisited. First, these set of authors published in 2017 and subsequently they published in 2019 as a daring discourse. So they have cited certain alternatives which we have been trying also. One is a superior trunk block plus supraclavicular nerve block from the cervical plexus. Costoclavicular block has been reported to give 0% of phrenic nerve palsy chances. Shoulder block, which is a combination of axillary nerve block and the suprascapular nerve block, or the ISO block. ISO block stands for infraclavicular and subomohyoid approach to the suprascapular nerve. These are some of the alternatives which have been cited in the literature. So to summarize, my dear friends, interscalene brachial plexus block is an intermediate to advanced level block. Neck is quite a neural and a vascular structure, so thorough knowledge of anatomy and sonoanatomy is very essential. It provides excellent analgesia and anesthesia in case you desire for shoulder and proximal arm surgeries. And we all know that C8 and T1 sparing can occur in the distribution of the ulnar nerve. That is why it is not suitable for surgeries distal to the mid-humerus. In my opinion, periplexus approach should be used because you are all postgraduate students who are in maximum numbers who are attending this class. This is on the basis of literature as well as my personal experience. Analgesia, you need 6 to 10 mL. Anesthesia, you require around 15 mL. So thank you very much for patient listening. Any questions? If you have, I'm more than happy to answer.
Suprasad sir.
Thank you, Divesh sir. It was a very nice presentation, very enlightening. I think we have seen some new perspectives from your presentation, sir. We'll definitely try to avoid the French block here afterwards. Thank you very much, sir.
There's one question in the chat box.
Choice for clavicle fracture surgeries, sir.
So clavicle fracture surgeries, interscaling gives a good coverage. Okay. But if you are going to reduce the volume, which should be the trend, we give a separate supraclavicular nerve block in between the sternocleidomastoid and the top surface of the middle scalene muscle, in between the deep cervical fascia as well as the prevertebral fascia. 3 to 5 mL can be deposited for supraclavicular nerve block. Another block which has been recently described is the clavipectoral fascia block by Louis Waldes, and we have tried in a couple of cases. It works very beautifully. On either side of the clavicle fracture, coming from caudal to cranial, we can deposit 10 to 15 mL of the drug in between the periosteum and the clavipectoral fascia. So majority of the nerves to the clavicle are getting supplied through the clavipectoral fascia. So that is another choice.
Thank you, sir. Is there any method where we can reduce the chances of ulnar sparing, sir?
Ulnar sparing can be reduced if we target the lowermost trunk. That is possible if we go to a level intermittent between classical interscalene and the supraclavicular, and we target the lower trunk also. Supraclavicular, definitely we give first a corner pocket block, so lower trunk will be targeted. But if we deposit the drug close to the C7 level, then drug and 15 mL will trickle down towards the inferior trunk. So this is how you can reduce the chances of ulnar sparing in case you intend to give interscalene for surgeries below the elbow.
I think Advisor, shall we move on with the next presentation, sir?
Okay, okay. Thank you, sir.
Thank you, Divesh, sir.
Thank you very much for having me on your platform.
We are also grateful to you, sir. Thank you very much, sir. The next presentation is the journal review by Dr.J. Sarvavinothini. She is a senior consultant in MAOT International Hospital. She is a very good academician and very interested in pediatric anesthesia. Over to Sarvavinothini. Welcome to the forum. Welcome, sir. I can start.
Good morning, everyone. Today's journal club presentation is about an article that is published in BMC Anesthesiology in the year 2020. It is titled as The Modified Ramp Position, a new position for intubation for obese females. It's a randomized controlled pilot study done by Ahmed Hassanin et al. The aim of the pilot study was to understand the feasibility of the modified ramp position for laryngoscopy, especially in obese females, compared to the traditional ramp position. This modified ramp position was known to offer slight neck extension than that offered by the ramp position. And it was suggested to bring the breast away from the laryngoscope and also aid in the laryngeal visualization, especially in obese females. This was a randomized control study done in Cairo University between September 2018 and February 2019. It was done in obese female patients with a BMI of more than 35 kg per meter square, and those patients who had a limited neck extension, or those who were edentulous, and those who had facial or neck scars were excluded from the study. All the patients underwent a preliminary airway assessment using the Malampatti grading, thyromental distance, and neck extension measurement, and the patients were randomized into two groups, either ramped group or a modified group. There were totally 60 patients, so 30 patients in each group were randomly allotted, and the basic pre-induction monitors were attached, and the ETCO2 was attached post-induction. In the patients who were put in ramp position, the shoulders and the head of the patients were elevated such that a horizontal alignment was achieved between the external auditory meatus and the sternal notch. In the patients who were allotted for the modified ramp position, this position was achieved using a special pillow known as a Hassanin pillow. It is named after the author of this article. And this pillow's dimensions were the height and the length were 15 and 60 centimeters respectively. In this position, the shoulders were elevated and the head was also extended to the most possible range to bring the breast away from the laryngoscope. So this is the comparison of the ramp position versus the modified ramp position, wherein we can see a bit more neck extension offered here. After the preliminary pre-medications, the patients were induced with propofol, atracurium, and fentanyl, and all of them were mask ventilated for 3 to 4 minutes, and the laryngoscopy was performed using size 3 Macintosh blade. Cormack-Lihan grading was also noted. And if the laryngeal visualization was not sufficient in the modified ramp group, the head was manually elevated to achieve the ramp position. And this was termed as a rescue maneuver. And all the patients were intubated with size 7 or 7.5 ET tube, and the position was confirmed using capnography. What is the primary outcome that was measured? The primary outcome that was measured was the incidence of difficult laryngoscopy. And the authors have defined this as the failure to insert the laryngoscope into the oral cavity due to the interference of the large breast, or the need to reposition the patient to insert the laryngoscope. Reposition was defined as the need to make any alterations in the position, like extending the patient's neck or elevating the patient's shoulders or manually moving the breast away to avoid the interference with the handle of the laryngoscope. The secondary outcomes were the time till the complete visualization of the vocal cord, the time taken for endotracheal intubation, the Cormack-Lihan grading, the incidence of relatively difficult mask ventilation, the number of attempts that was made to insert the endotracheal tube, and any incidence of hypoxemia or airway trauma was also noted. This is the base of the study. It consisted of 60 patients who were randomized into 30 each in each group. And the results, as we can see, the demographic data and the baseline groups were comparable in both the groups, all having a p-value greater than 0.05. And the modified ramp group showed a lower incidence of difficult laryngoscopy, 3% in comparison with the ramp group, which had 45% incidence. And this modified ramp group patients also had a lower incidence of difficult mask ventilation, as low as 20% as compared to 83% in the ramp group. And they also had a shorter time of blotted visualization, almost 4 seconds shorter. And they also had a better Cormack-Lihan grade view. And none of the patients in this modified ramp position needed a head elevation to improve the laryngeal view. There was no incidence of hypoxemia or airway trauma. So as we can see, all had a very highly significant p-value of less than 0.001. The discussion as done by the authors, the sniffing position is achieved by flexion of the neck at C5-6 by 35 degrees. This is achieved by head elevation by placing a small pillow under the occiput, and extension of the head by 15 degrees at the level of the atlanto-occipital joint. This is achieved so as to align the sternal notch to the external auditory meatus. On doing so, we align all the 3 axes, the oral, pharyngeal, and the laryngeal axis, to optimize the laryngeal visualization. But such position, when adopted in obese patients, it doesn't result in a sniffing position because of the increased fat deposition that is there in obese patients, which increases the anterior posterior chest diameter. They achieve a lower head position with just a pillow is placed under the occiput. So in order to achieve a clear position to align all the 3 axes, the ramp position was proposed to overcome this problem. So that this ramp position was proved to be superior to the sniffing position in both obese and non-obese populations in this study done by Lebowitz et al. And published in the Journal of Clinical Anaesthesiology. And it is also proposed to be more favorable even in patients with expected difficult intubation in the studies done by Lee et al. And published in Korean Journal of Anaesthesiology. But there are other group of people also who had a different opinion and who favored the sniffing position, like Semler et al. So this was controversial to either go for a sniffing or a ramp position. And now the authors of this article have come up with another different position called as a modified ramp position, using this special pillow that we had seen already. So they claim that this achieved more head and neck extension than that achieved in the ramp position. So it facilitated the insertion of the laryngoscope into the oral cavity, it improved the mask ventilation, and it improved the grade of the laryngeal view. The authors argue that it facilitates the insertion of the laryngoscope into the oral cavity because the neck extension offered more space for the handle of the laryngoscope, and it was much away from the breast of the patient. It improved mask ventilation because the extension achieved It allowed for the easier movement of the jaw. The jaw now moved in two directions, both anterior and the caudal, when someone is manually lifting the jaw. And it offered better airway patency as compared to the ramp position, wherein the jaw moves only in one direction, that is only in anterior direction. And it also offered a better laryngeal view. The authors also argue that though the alignment of oral, pharyngeal, and laryngeal axis is confirmed by MRI in sniffing position, such confirmation is not there. It is only a theoretical assumption for a ramped position. So they claim the modified ramp position to be favorable. The limitations of this study, as claimed by the authors, are it is a single center study and it did not enable blinding of the physician, and it investigated all the outcome only in the elective and stable patients, and the need for it to confirm an emergency endotracheal intubation is there. So this ends this article. Now let us investigate further. The lacunae, as we see now, was the neck circumference was not mentioned in this study. Is the neck circumference important? Yes, it is important because there are two kinds of obesity that we come across, android and gynecoid. In the android type of obesity, the fat is mainly central area. The fat is mainly distributed in the face, cheeks, and more in the airway also. So it leads to a limitation of the cervical spine movement and atlanto-occipital joint movement. And there is a large tongue and large amount of soft tissue and high anterior larynx. So these factors alone contribute for a difficult mask ventilation and tracheal intubation. And also a difficult intubation as high as 13% of the patients. Whereas in patients with gynecoid type of obesity, the fat is mainly in the arms, legs, and buttocks. So if the neck circumference was mentioned, we might have had a better idea about the difficult intubation outcome also. So that was not mentioned. So that bias is not yet ruled out. Now, exploring further, the sniffing position was first described by Sir Ivan Miguel almost 100 years back, almost in 1930s. So he said that by placing the pillow of around 7 to 10 centimeters under the occiput, neck flexion is achieved of around 35 degrees at the C5, C6 level. This aligns your pharyngeal and the laryngeal axis. And on extension here at the atlanto-occipital joint of around 15 degrees, the oral, pharyngeal, and the laryngeal axis are aligned, and it improves your glottic visualization. There is a two-curve hypothesis also. This is a primary curve and this is a secondary curve. And we can see it is all the true curve is not in alignment or it is not flattened. So on achieving the sniffing position, this true curve gets flattened and the visualization of the glottis is much easier or much favorable. So we can see it dynamically in this video. On achieving the sniffing position, we can see all the three curves get aligned. So all the three curves get aligned and the glottic view becomes better. On reviewing other peer articles, this article was published almost 20 years back in Anesthesiology by Jonathan L. Benumov. Benumov, as we all know, is a pioneer in thoracic anesthesia and airway. He has titled this article as the comparison of the intubating positions. The end point for the position should be measured. He states that by elevating the occiput by 7 centimeters, we achieve 35-degree flexion of the lower cervical spine and we achieve the sniffing position in normal patients. But the same thing by keeping a pillow in an obese patient, it will not result in a sniffing position most of the patients because they have an abnormally contoured scapula, abnormal deposition of fat under the shoulders and the nape of the neck. So in order to just achieve 35-degree flexion of the cervical spine and also extension, we need to ramp them up with towels and blankets. So how is it? So we can see here that by just placing of the pillow, we achieve the alignment between the external auditory meatus and the sternal notch. But this is not possible in an obese patient. So just placing a pillow, their head lies at a lower level. So in order to achieve this alignment, we need to wrap them up with towels and blankets. So we can see that. So we need to achieve the alignment, we need to wrap them up. So this was first told by Benumov. And first study regarding the ramped position was done by Collins, and it was published. It was titled as a laryngoscopy and morbid obesity in comparison of sniff and ramp positions. So here he studied these outcomes in 60 morbidly obese patients, and he had grouped them into two. In group 1, they assumed a conventional sniff position. In group 2, they were placed in the ramp position. So, and the results were the ramp position showed improved laryngeal view when compared to the standard sniff position. So this was the first study that was ever done in comparison of the ramp versus the sniffing position. This is a study that has been very recent. It's published in 2020 in Hong Kong Journal of Emergency Medicine. It is done in a mannequin. It's a crossover mannequin study. So the patient bias is ruled out. Here they studied the endotracheal intubation, the ramp versus supine position. And here 4 scenarios were placed. Here the mannequin was placed in supine and in the ramp position. And in addition, the mannequin settings were also adjusted to simulate normal and difficult airways. And what was their outcome? They stated that ramp position performed better or equivalent to supine position in all the 4 scenarios. But it significantly improved the glottic view and intubator ease in difficult airway scenarios. And they suggested some more studies to be done on real patients to conclude. So on reviewing the meta-analysis, this was published in Brazilian Journal of Anesthesiology. It was a meta-analysis comparing the ramp position and sniffing position done by Samuel et al. They analyzed 4 randomized control trials and 3 cohort studies, and they concluded that ramping position is associated with improved laryngeal exposure in surgical patients, and they recommended that clinicians should consider this position for intubation in all surgical patients. So how do we achieve ramp position? It can be achieved using blankets or any OT table with controls, or there are many commercially available devices also, right? The rapid airway management positioner, Oxford head elevating pillow, or Troop elevating pillow. So these are the various methods by which we can achieve the ramp position, blankets or other pillows, the OT table. And this is a rapid airway management positioner, which has an inflatable positioner it is. So this can be inflated using your foot pedal or using your hand gear, and it can be rapidly deflated also. So you need not reposition the patient. The other modifications or synonyms of this ramp position are head elevated laryngoscopy position, bed up head elevation, or flex tension. We need to understand that ramping up doesn't mean just head up. If you just do a head up, you're not going to achieve a better position at all, because the neck is still going to be flexed. So you need to ramp up and also do the sniffing position. So ramping up is not just head up, it is a head up and a sniffing position. So you need to do a head up of 20 to 25 degrees and also achieve a sniffing position so that it is a correct ramp position. Because mere 25-degree head up is not going to cause any change in your in the alignment of all the 3 axes or in the flattening of the 2 curves. So this is the study done by Greenland et al. And we can see that mere 25-degree head up is not going to do any change. So you need to do a head up and the sniffing position such that the oroglottotracheal curves align with the viewing angle. So always remember to ramp up correctly. Just head up and just stating that your external auditory meatus and your sternal notch is in alignment is not going to offer great benefit. You need to do a ramping up position like head up and a sniffing position. So only then that is termed as the proper ramping up position. So we always demand something extra. So does this ramp position offer something extra other than better laryngeal view? Yes, it does, because in many obese patients, when they are placed supine, we can see that there is a greater reduction in functional residual capacity, as great as 50% when compared to 20% in the normal population. And there is a greater reduction in the pulmonary complaints and a larger VQ mismatch. So in obese patients, you always have a limited cardiopulmonary reserve, and they are more prone for right heart failure. So in patients who have inadequate cardiac reserve, when they are placed supine, they might even go for a fatal cardiorespiratory decompensation, also termed as an obesity supine death syndrome, and reported by Lemizzi M. et al. So all these can be averted if they are placed in a ramped position. And Dixon and colleagues have also shown that there is a 23% improvement in the mean oxygen saturation when obese patients are placed in 25-degree head-up position. So ramp position does offer other physiological benefits also. So back to our parent article, the ramped versus the modified ramp, which is more favorable. Here, if we see, this position offers some more extension. Like this seems to be more like a ramping plus a sniffing position. So that is why might be this offered a better laryngeal exposure, better ease of laryngoscope insertion, etc. So the lacunae now, as we see after reviewing all the peer articles, we mentioned earlier that neck circumference was not mentioned. That bias has to be ruled out. And now there were other questions that need to be clarified. Was the head extended during laryngoscopy in the ramped position? Was that patient placed on a sniffing position also when the patients were when laryngoscopy was done in such patients? And what was the degree of neck extension achieved over and above the ramp position using the special pillow during laryngoscopy? So the endpoint of these two positions are still unclear. So if that is all made, then we can come to a better conclusion. So how do you conclude now? The correct positioning of the patient is important for proper airway management. The future airway guidelines should include this aspect also. Ramped position when done correctly. That is when it is a combination of a 25-degree head up plus a sniffing position. It does surely have some anatomical and physiological advantages, especially in obese patients. But further research is required to clarify the critical aspects of the head and neck positioning and the use of other special devices or special pillows and special airway management devices. So the research needs to be continued. Thank you.
So, Professor, thank you, madam, for elaborate analysis of this ramped up position and comparing with the sniff position. Thank you, Ananda.
I think this presentation will benefit the PGs very nicely, sir. The messages you should also extend, just not keeping it ramp. I think we have one question from Somu sir. Is that what was the Malampati score of the patient studied in this journal?
It was all between 2 and 3. Most of the patients were between 2 and 3. In the studies in which it was done, the BMC anesthesia it was published, none had Malampati 4, I believe. It was all between 2 and 3. If you want, I can show that article.
Okay. Shall we continue the surgery in the same position?
If the surgery is going to be in a periphery, like in limbs, or then if this position is not going to interfere with the surgical position, then the surgery can be continued in the same position. If the patient is not going, there can be some hypotension also. If such adverse things are not there, then yes, surgery can be continued. Otherwise, then you'll have to reduce the amount of the head up position. If it's in an operating table, it is easier to do that. And that is why this rapid airway management position or the ramp that has been advertised. It is a pneumatic thing. You can just connect it off to the medical air, and it can be your foot pedal or your hand lever can be used to inflate and deflate it. So then the burden on other personnel will be reduced.
Definitely, removing it again.
In a super obese patient, removing it is also a huge task. So
but I think if it is for a bariatric surgery where it will be very essential, I think we have to remove it and place it in another position.
So then that can be used. But still, further research needs to be done to determine the efficacy of all these devices.
Thank you, Sarvavinothini. It was a very nice presentation.
Edward, can I come in?
Yes.
Edward, very nice topics, and I think excellently covered today. I have some basic thing because with regard to the ramp position in a normal patient, I think we have to do some studies with regard to the hemodynamic status during intubation. So I think that will help the thing to normalize whether it should be needed in a normal patient. So because the article has said all surgical patient may be placed in the ramp position for intubation, that also will aid in a better way. So that with all the induction agents and the hemodynamics may be monitored. That is one thing. Second thing is the segmental spinal anesthesia. I think maybe this is one of the cases where they came out with without any problem, or whatever the problem come, they are able to manage. Actually, she said the level is around T4. Okay, the level she attained is T4. I don't think with the respiratory 50% compromise and other things, whether it is better to go for a T4 level block. And we actually, I think most of the government hospital now, they have very more done COVID cases under regional anesthesia, most of them. Actually, we have done around 500 cases in KMC, and 99% we have taken under regional anesthesia only. Only thing is that the level of block, we try to keep below T12. So with that only we maintained, and we were able to come out clean on this part. With regard to segmental anesthesia, if it's adequate, anesthesia is not adequate, then it also will lead to other problems, which I think they were not gone through. So that's the reason why they escaped. So I think segmental anesthesia also, if needed, the students can take it up as a study with all the other drugs and other things. I think they can come out with papers. Thank you.
Thank you, sir. Thank you. So, Professor.
Thank you very much, sir. Do we have time, sir, for a few questions?
12 o'clock, we will finish.
Yes, sir. We will finish it, sir. We will go on with the questions in the next session, sir.
Okay.
In the next week, we have a very interesting discussion on acid-base physiology by Sanjay Pandya, sir. So PGs, be ready for the fiesta next week. And we'll also have a quiz which we'll carry over from this and the next week quiz. And the next week, we'll have a video presentation on anesthetic management of foreign body in airways by Dr. Praveen, sir. And another journal review by Edward, sir. Thank you for joining all us today. Thank you very much.
Thank you, everyone. It is a online anesthesia for postgraduate teaching on Zoom platform. It is sponsored by Acryla and is hosted by Logistic. Thank you, one and all.